Hearing loss basically means that an individual is not hearing as well as they normally do. Hearing is a very complex yet simple situation, because what happens is that sound has to travel through your ear. Your ear has three parts. We have an outer ear, a middle ear, and an inner ear. The eardrum, or what is called the tympanic membrane in medical terms, is the limit of the outer ear. Behind the eardrum, we have the middle ear. The middle ear cavity is an air-filled space, and it has three small bones called ossicles that transmit sound. That sound is further transmitted to the inner ear and then via the nerve to the brain. So when a patient perceives sound, the first step is that the sound must pass through the ear canal. It hits the eardrum, it makes the eardrum vibrate, and then now stimulates the three small bones to push that sound along the sound pathway. The sound will then travel through the inner ear, through the nerve, and that is how the patient will perceive that they have heard a sound, because the brain is able to tell you what that sound is. That is a car hooting, that is a door banging, that is somebody speaking, and that is how you're able to interpret what you hear. And the brain has milliseconds to do all this, so you can imagine that this process happens very fast. So when a patient talks about hearing loss, it means that they are not hearing the way that they're supposed to hear. But then this falls into different categories because we have different types of patients. We have our newborn patients who are brought in by their parents. This is an individual who cannot speak, because we know babies learn how to speak from around the age of 1.5 years and beyond. So at this point, it is up to the parent to recognize whether there's a hearing loss. In the initial first 2 to 4 weeks, you might not get these patients, but after a while, the mothers come, especially mothers who've had other babies. They will tell you that this baby does not turn their head. When a door bangs, when something falls, my baby does not turn their head. When I sing to my baby does not seem to respond. When I speak to my baby does not seem to respond. When in a noisy place, the baby does not seem to interact with the environment. So that is the first step, that the parent comes and reports that I think that there's something wrong with my baby, because this baby is not responding to stimuli which they should ideally respond to. And then now we have the toddlers. With the toddlers, what usually happens is that as you follow the milestones, it is expected. They begin by babbling, okay, because they cannot speak, humming and making out words that the parents cannot really interpret, but they are showing that this person can speak. If you switch on the television, you notice that the child focuses on the television and may try to imitate what they're hearing. If we play some music, you find that the baby might try to dance, actually turn their head towards the music. If somebody calls their name, you find that the child is able to turn towards the person who has spoken their name. So at this point in time, the parents will bring in the child if they notice that when I call out my baby's name, my baby does not respond. When we switch on the TV, the child is not interested, or it's like they cannot hear. When they compare with other children the age of their child, they find that my child is not responding in the same manner as my neighbor's child is, my friend's child is. So actually you find that when they get to the age from around 10 months to 1 year, that is the time we start seeing a lot of them, because someone will come and tell you my sister's baby is the same age as my baby. That baby can say mama, can say baba, my baby is not speaking. And then now we also have the children who are school going, who know how to speak. They've actually developed language, but then now the parents bring them and say, nowadays it's like this child seems to be ignoring us. We call him, he does not respond. The teacher has reported that the child is inattentive, does not seem to be listening in class, does not answer questions. And then now we have the older age group, the people who are now aging, what we call presbyacusis, age-related hearing loss. As we all grow older, our hearing begins to diminish. So we also have the age group of patients who present from between the age of 55 upwards, and they come and report to you that I sit in meetings, I cannot hear what everybody is saying. I have put my phone on maximum volume, I cannot hear. I now use my phone on loudspeaker, I cannot hear. So we have different categories of the patients who have hearing loss. We have different types of hearing loss. As I explained before, we have the different parts of the ear. So we have what is called a conductive hearing loss. A conductive hearing loss basically means that there's something that is obstructing the passage of sound. Thereby, the person is not able to hear as well as they do. In the outer ear, some of the things that can contribute towards a conductive hearing loss. The ear canal can be packed full with wax. You can have a foreign body. Children insert foreign bodies in there. They can put in pieces of paper, they can put in Tic Tacs, they can put in plasticine. So in that manner, the sound is not able to get to the eardrum. The eardrum can therefore not reverberate and transmit the sound further along the pathway. So that is one of the causes of conductive hearing loss in the outer ear. In the middle ear, you can have fluid. The middle ear cavity is supposed to be an air-filled cavity, and its contents are the ossicles that transmit the sound. If you have fluid in the middle ear, it means then you're impeding the movement of the ossicles. They're not able to move in the manner that they should. So because they are slowed down, then even the transmission of sound is also affected. So if you're able to get rid of that fluid, you can do away with that form of hearing loss. Sometimes we have some tumors that can happen, or some masses can grow in the outer ear. You can have masses that can occur in the inner ear, and those also contribute to the hearing loss. So basically, a conductive hearing loss is caused by something that can be removed, and if that thing is removed, then you can reverse the cause of that hearing loss. Then now we have the second type of hearing loss called sensorineural hearing loss. Along the pathway of hearing, we have the vestibulocochlear nerve, which is responsible for transmission of sounds to and from the brain. So if this nerve is affected, and this is usually what happens in some disease processes, you might find that in congenital diseases, there's some children who are born with congenital hearing loss because their nerves were affected while they were still in the uterus, and now that nerve is affected and they have a sensory hearing loss. In age-related hearing loss, you also find that the nerve also becomes affected, so that is why we have the sensory hearing loss. Some disease processes can also affect the nerve, and thereby you have the sensorineural hearing loss. The third type of hearing loss is what we call a mixed hearing loss. We call it mixed because it is a combination of the conductive hearing loss and the sensorineural hearing loss. So we call it a mixed hearing loss. So with the sensorineural and the mixed hearing loss, you have to find what is the causative factor. Some we're able to fix, some we're not able to fix. So if we're able to fix it, then hopefully we can reverse the hearing loss. If we're not able to fix it, then it is a permanent hearing loss. We can categorize hearing loss in a number of ways. The easiest way to do it would be what we call congenital versus acquired causes of hearing loss. When the baby is in the mother's uterus, the baby is subject to everything that the mother is exposed to. If the mother gets some conditions, for example, like rubella or syphilis or toxoplasmosis, you find that these conditions can actually affect the baby while in the uterus, and they can affect the hearing. And now the baby will actually be born with a hearing loss. Medications that the mother may take while she's pregnant can also affect the baby's hearing. Sometimes we have some congenital syndromes which occur. You find that in families. So you find that as part of these syndromes, that there could be a hearing element that is attached to it. With a congenital hearing loss, unfortunately, you will never know until the baby is born. While the baby is in the uterus, you're not able to tell that the baby has a hearing loss. So once the baby is born, in the hospital, we usually do an assessment for every newborn child that includes the newborn screening. And at that level, we're able to tell, does this child have a hearing loss or not? Even at that level, some of the congenital causes of hearing loss can be dealt with, and you can be able to reverse some of them, and the baby will be able to hear well in the future. Unfortunately, there are also some conditions that we're not able to reverse, and now that baby will actually have a permanent hearing loss. But then there are other ways to deal with that type of hearing loss, with a permanent hearing loss. The acquired conditions basically means that this is a hearing loss because of things that you are not born with, but you have come across in your life as you go along. We already talked about some of them, like the foreign bodies being inserted in the ear, tumors or masses in the outer ear or in the middle ear, what we call otitis media with effusion, which is very common with young children, and they have fluid in the middle ear that can contribute to the hearing loss. And then we also have the other major causes that affect the nerve. Those include different syndromes, they include chronic illnesses. Patients who have diabetes, hypertension, and other chronic illnesses are also predisposed to hearing loss. Patients who develop some tumors, even of the postnasal space or ear tumors, are also predisposed to hearing loss. So basically, as you try to determine the cause of the hearing loss, before you can categorize, you need to find out, is there any underlying cause that you can aptly diagnose, and then you'll be able to tell what is the type of hearing loss. The first step is what we call the history. The patient themselves will present to the doctor and they will say, I think I'm not hearing well. And then they'll be able to explain their symptoms. So from the doctor's point of view, the first thing you want to know, for how long have you not been hearing well? Is it both ears that are affected, or is it one ear that is affected? Have you had any discharge coming out of your ears? Have you inserted anything into your ears? Have you received any form of trauma? Were you slapped? Were you hit? You know, anything that you can actually try and attribute to the cause of the problem. You want to find out, are there any congenital issues in this patient's history? Do they have a family history of hearing loss? Do they have a family history of syndromes that are attributed to hearing loss? And then you also want to find out, does the patient themselves have any chronic illnesses? What medication is the patient on? How long have they been on that medication? That is the first step. The second step is now you actually examine the patient. You do an ENT head and neck examination. You examine the eyes, you examine the nose, you examine the mouth, and then you go to the ears. When you're examining the ears, the first step you want to see, is there anything obstructing the ear canal? If there is something obstructing the ear canal, and then you remove it. As an ENT, every time you do an otoscopy, an otoscopic examination of a patient, you must see the eardrum. You cannot actually make a conclusive diagnosis if you're not able to view the eardrum. So if there's anything obstructing the passage, you clear it out and you look at the patient's eardrum. Because even one of the things you must confirm, is there an eardrum? You might find that the patient might actually have a perforation of the eardrum. That contributes to a conductive hearing loss. Is there anything beyond the eardrum? Are you seeing fluid in the middle ear? Is there anything else that you think could be within the middle ear? Then the next step, we have the tuning fork test. We usually use a tuning fork. This is just a tool that is used by the ENTs in the office, and it is 516 Hertz. And what you do is that it produces a vibration, it produces a noise that can be heard by both myself, the examiner, and by the patient. And we do some tests called Reiner's test and Weber's test, and these tests help us to tell at a clinical level what type of hearing loss does this patient have. Once you make the clinical diagnosis, you need to confirm your diagnosis. We're living in an age of evidence-based medicine. So now we have the tests that we actually do with the machines. We have what we call the pure tone audiometry. So the pure tone audiometry is the patient wears some headphones and some sounds are transmitted to the ear. And the patient is able to tell us if they can hear the sound at a certain frequency, at a certain level of loudness. And with that, we're able to plot a chart. And from that chart, we're able to tell what type of hearing loss is there. We also do a test called tympanometry. The tympanometry is basically to assess the middle ear. It'll tell us what is the pressure in the middle ear. Is the pressure too high? Is it too low? Is it fluid? So as we move along, we can also choose to do other further tests. For the young children, of course, they're not able to follow instructions, especially below the age of 2 to 3 years. So we have the tests that we do even in a hospital setting, in a clinical setting. We have what are called the autoacoustic emissions, which we can actually use to tell as a quick measure, is this ear producing vibrations? Is this ear hearing? Then we have what we call the ABR, acoustic brainstem reaction test. And for this one, we do for the younger children, but they require to be sedated. So the baby is put to sleep and we do the test. And it also draws some certain graphs for us, and it tells us, is this patient hearing? Is the hearing normal? Or what level of hearing loss do they have? So at that level, those are just the basic tests that we can actually use to determine, is this individual hearing or not? From there, then you're able to decide the mode of treatment depending on your clinical findings and the history. First, we have to determine what is causing the hearing loss, and then you can determine the treatment. For some things, yes, we can say there's some operations that can assist to improve the hearing loss. For example, if somebody has a mass that is growing in the outer ear canal, or there's a mass in the middle ear, we can actually operate and remove that mass. And by that way, we hope that we can improve the hearing. If the patient has a tympanic membrane perforation, we can actually perform an operation called a tympanoplasty, where we put a graft, or what would say a new eardrum. That would also improve the level of hearing. So we have different surgeries to treat different conditions that can contribute to the hearing loss. But that is not a guarantee that the hearing will go back to normal. The hearing will improve, but it may not go back to the normal type of hearing. The medications to improve hearing are really not there. If you have wax, the medicines that we put in the ear canal to make the wax soft, and we clean it out. If a patient has infections, like chronic otitis media, we treat the condition with medications, but that does not mean that the hearing loss will be changed or the hearing loss will improve. We'll have to undertake other measures now to sort out the hearing loss. The reason we prescribe hearing aids to patients is because a patient has reported that they're not able to hear properly. We have done the necessary history taking, the necessary clinical examination, and we've done the necessary tests to confirm what type of hearing loss that they have. When we chart the graph, there's a certain level of hearing that we look at that helps us determine whether a patient is going to wear a hearing aid or not. The purpose of a hearing aid is to amplify the sound in the environment and put it together and present it to the hearing aid, and the patient is able to hear the sound better. So in that way, we can actually say that their hearing has improved. So most of the time, patients who have age-related hearing loss, presbyocusis, we prescribe hearing aids to them. Patients who have conditions whereby their nerve is affected, we also prescribe hearing aids to them, because now they have the sensory neural hearing loss, which, as I told you, is not usually reversible, and you need the patient to hear. Especially with young school-going patients, we are very keen on making sure that they can hear well, because a patient who cannot hear cannot learn. So we are very keen on making sure that if indeed we find that we're not able to reverse the hearing loss in young patients, we make sure that we get them the hearing aids that they need. We also have other modalities of dealing with hearing loss, like the cochlear implants, which are now being done in Kenya, right here at Nairobi ENT Clinic. And the cochlear implant by itself, the whole procedure may be expensive, but it's a very good tool, and it actually helps to deal with some of the congenital issues of hearing loss.